majority of the time, we still have that top-down approach. Decisions about global health, decisions about a woman who lives in the slum next door to where I live being made thousands and thousands of miles away from her. And the persons around her who live in community with her are not able to feed into that system of knowledge development so that we can co-create solutions that are contextually relevant to that woman.
You're listening to Patterns and Meaning, a podcast by Seed Global Health. We find meaning in patterns, connect history to the present, and illuminate the way forward in global health. I am your host, Edem Tokunu. I am honored to have Dr. Rose Clarke Nanyonga in the guest chair today. Dr. Rose is the award-winning Vice Chancellor of Clarke International University in Uganda. She also holds a senior faculty position at CIU, teaching health policy and planning, advanced strategic management at the graduate level, and various executive leadership courses. Dr. Rose is one of only 3 women vice chancellors in Uganda and the first female vice chancellor who is also a nurse by background. Welcome to Patterns and Meaning, Dr. Rose. I'm really excited to have you as a guest today.
Thank you, Edem. I'm delighted to be here. Thank you for the opportunity to have this conversation.
Awesome. So Dr. Rose, you're one of 3 women vice chancellors in Uganda. And in some ways, this is a microcosm of global health where women make up 70% of the health and care workforce, but they hold very few leadership positions. At the same time, global health leadership is overwhelmingly white. So from your experience, what are the visible and invisible systems that have created this gender imbalance and lack of diversity in global health leadership?
I think we need to start looking at the disparities in global health and in global health leadership within context and try to understand what those data in context are telling us about, for example, families at the family level, at the community level, at organizational level, at national level, as well as at the global level, looking at the social norms and structures that exist within all of those levels. For me, the outcome of what the statistics represent reflects an interlinked condition and structures that are created, but structures that are also inherited and structures that are also maintained at all of those levels. So invisible, normalized, and inequitable systems exist at family levels, for example. When I was preparing for this conversation, I looked at one of the studies that was done by some colleagues here in Uganda in 2018, and they explored the unequal power and gender norms and how these expose adolescent girls to higher risks of HIV, of early marriages, of pregnancies, and of coerced sex. The researchers also looked at the social construction of gender norms from early childhood. And what I found important was how those actually influence adolescents' agency. In Uganda, we have a pregnancy rate of 25%. I'm sure, Edeme, you are familiar with this data. That is only slightly lower from the overall 28% of other sub-Saharan African countries. So the cumulative risks for such teens include, maternal and child health, stigma, isolation, and safe abortions, failure to continue with their education, and a perpetuated cycle of poverty. For many years, for example, in Uganda, primary and secondary school, if a child got pregnant and they were within that track of secondary education, They were not allowed as pregnant teens to actually remain in school. And it's still the same today. There was just so much stigma. So they automatically drop out of the school. So we need to understand the problems from starting at that level. What is happening within our households? What's happening at the family level? Because that is really the pipeline for a global health leader like you and I. We grow up in certain families that shape who we later become. If we do not create opportunities to keep the African girl child in school, for example, or create some safety nets or some abridged programs that allow them to return on track, and for many do not, complete their high school, then we subsequently do not have a pipeline that can feed into the global cohorts of global health leaders. And this is precisely why I think when we look at global data, the striking disparities among global health leaders, we really must understand them from these areas where most of the interventions, that we are thinking about need to start at that level, at the family, at the community. And then we expand those, within the organizations and at the country level. These socially constructed norms, whether they are visible, whether they are invisible, need to be acknowledged, but they also need to be understood and addressed at those levels.
So it starts way before the person becomes a nurse or becomes part of the global health community, way, way before.
Absolutely. One of the things that for me is really interesting is when you are embedded in an organization and within an organizational culture, is how cultures within our families actually find their way into the organization and they are sustained that way. It's almost like there is this inheritance of these norms that then when we come to organizations, when we think about policies and organizational cultures, those are the elements that we integrate within those structures. So if we are going to start challenging as women leaders or as men who are champions for global health equity, particularly for inclusive policies for women, we really need to start thinking about how do we treat our girl children at home? What are our own policies? What are our own norms within that family? How do we celebrate? How do we create equitable conditions for both girls and boys to compete and to have equitable access to resources, to education, to skilling, and to investment?
Thank you, Dr. Rose. So having global health leaders primarily from the global north results in centering Western knowledge systems. And how does this influence the response to health crises such as COVID-19 in Uganda and across Africa?
I think it's been really interesting to see how countries have responded to COVID-19. In Uganda, we have had a bit of a mixed model. First, even though we know that one size does not fit all, the majority of our responses were very much tailored, pretty much alongside the interventions that were being implemented in the global north. I'm sure that that is true for a lot of other countries in sub-Saharan Africa. On the other hand, Uganda, like other countries such as the DRC, have gone through cycles of Ebola and Marburg, cycles that have or should have allowed us to create context-specific knowledge and policies and that we can use or leverage some of that experience for the COVID response. And I think that Uganda, that's why I say that Uganda had a kind of a mixed model in our approach. The severest lockdown, even before we had any confirmed patient here, so at 0 patient, we had the country locked down, starting from the borders. Universities on March 20th were shut down completely. We had no vehicles allowed on the road except for essential services, or nurses and doctors had to be registered so that they could be allowed on the road. We implemented curfew. I mean, these were severe implementations. Of course, these are happening in the context of non-existing social protection programs. So you know that the result of some of these interventions, as implemented in the West and here, result in extreme food deprivation, in poverty, harsh financial realities, less access to education for many children, and of course adults in universities, and of course, limited access to health care because, people cannot move freely. The health-seeking behaviors of millions of Ugandans who have communicable diseases as well. So people had to be very careful, how to move and when to actually access care. And of course, that rapid shift does not allow for the optimum public health messaging, and also the language and knowledge that we have used, for example, to describe COVID and COVID-related interventions is very much influenced by the global north. So the community response to COVID is thus shaped by Western knowledge systems, and there's quite often a bit of a pushback by communities because, one, they think that COVID-19 is a disease for foreign countries. If we don't make an effort, to adjust that and to reshape and to have a significant paradigm shift in the way we are reframing the language and reframing the disease and the symptom profile, then it's not as easy to get the public health response that you actually, need from people to be able to prevent the epidemic. And while no single country could have prepared for this disaster, I think it does bring to the forefront some gaping holes in our systems, in our policy, and as I mentioned, in our language and in our practice. And in general, it speaks to the fragile states, and it challenges us to develop and grow strong and responsive and enabling knowledge and structures to respond not just to the pandemics, but actually to the regular population health needs that we have in the country.
We also implemented a lockdown. I think after the first 2 cases, then there was a lockdown, but we could only manage it for 3 weeks. And after 3 weeks, people's pockets would not allow any more of the lockdown. And now that cases are rising, like currently cases are rising and our health system is overwhelmed because there aren't enough beds in hospitals, we can't go on a lockdown because it's just not economically possible for us. So do you think that it was hard on people, but do you think it helped in any way in trying to control the pandemic?
Yes, it did. It's interestingly that our results were quite impeccable at the very beginning. But like you said, the response actually sort of mirrors what you guys are experiencing. Our lockdown was longer, 3 months, nearly 6 months. Up to now, universities have not been fully open. We only got a presidential directive 2 or 3 days ago, I believe, for the universities to open in a staggered manner. Now, there were some other alternative interventions to allow universities to operate online. But to go back to the general response of the community, what we see now is we have significant community spread. And In fact, this is probably the time we should have had the lockdown. But because we had the lockdown much earlier on, it impacted people so severely that nobody is willing to stay home. In fact, when you walk into the rural settings and, even in the urban areas, people tell you straight up, something else is going to kill us and it's not going to be COVID, because they're so desperate, to safeguard their livelihood, to feed their children, to keep their children, to get their children back in school, simply to operate business as usual. So it's very difficult. I think now, the public health message really is much more the community needs to respond to COVID, but the community is responding to needs that have been created as a result of our COVID interventions.
So, what steps can we take at the individual, institutional, and structural level to ensure that global health leadership actually reflects diversity and the needs of communities and organizations it tends to serve?
We do have a lot of conversations about global health needs and global health programs. And like you, I'm part of a growing forum of these conversations. And so my response really here is that I think we need to first transform our conversations into action, or find a framework that harnesses all that voice into action and strike a balance, between identifying and framing the problem to actually intervention, identification, and implementation. And this is going to take quite a bit of work and a redirection of how global health interventions are piped down, whether they are coming from the global north to the global south, or from the global south to the global north, although I don't think that we've created a robust framework for that kind of transfer of knowledge. But I think at the local level, of course, like obeying my own transfer conversation to action, we need to think about diversity responsive policies from families to schools to organizations and to states, and to acknowledge that the current policies we have and the current norms we have are not adequate for us to get that level of equitable distribution and diversity to meet the diversity needs of the community. I think often we shy away from actually, having a candid conversation about what is broken, and instead we sort of rush in to, create another intervention. And that approach, I think we really need to revisit. So that's an intervention, a diversity responsive policy. And at CIU, at the university where I am, that's one of the things that we have done, that our faculty, whether female or male, they have to be paid the same amount of money as long as they are qualified to do the job. We shouldn't have any kind of imbalance in that, or that the promotion criteria shouldn't favor one or the other. So we have to be intentional as leaders who are already at the table to drive that. As I said, a candid conversation about social norms, as uncomfortable as this may be. I don't know if you read about some of the work that I've been doing to end child sacrifice in Uganda. And when we started the grassroots campaign in 2009, those were really uncomfortable conversations, because the practice of witchcraft is shameful and people tend to, they don't want to talk about it. They don't want to even come out and acknowledge that they engage in these kinds of practices. And yet the data do not lie. When you have children disappearing, being decapitated, and so on, you know that there is a problem. and that you know that there are underlying belief systems, and practices that inform those kinds of behaviors. So we started talking about behavior change communication. How do we have these conversations with each other about a subject that is quite uncomfortable? We can celebrate the rich heritage within African communities, but at the same time, we need to create space to challenge the toxic norms that damage both women and men's potential to operate as equals within the communities. But also, those are toxic norms that eventually inform how we cultivate our policies that impact healthcare delivery in the community. The other thing for us to think about is what I mentioned earlier in enlisting champions and balancing the conversations within ourselves, among ourselves, but also a conversation with other people, particularly men. Enlisting men as champions, I think, goes really a long way in making sure that both men and women receive equitable care. I think that if we have conversations that pit us against the men, particularly within our cultures, we are likely to lose the global health agenda. So I believe that, enlisting men and other women who are not part of this conversation as champions will go a long way in addressing the diversity needs. But also, I think that we need to be, and this is really where my work sits, we need to be intentional about enabling women for solution-driven conversations and not just problem identification. I think that we've spent a lot of time talking about bringing women to the table, creating space at the table. We even have catchphrases about this. For example, if there's no chair at the table, bring your own chair. Usually, women are on the menu but not at the table. So and all of those things reflect a sustained brokenness within our approach. So I believe that being intentional about enabling so that women who are the majority of healthcare providers, even within the community, are actually enabled to offer solutions and meet the community needs. Otherwise, we can't say, oh, they need to be at the table, but if they have nothing to contribute, then that's going to be a problem.
So, Dr. Rose, apart from your work with the child sacrifice situation, are there any organizations that you know of that are actually also using this sort of solution-driven approach and also having the candid, uncomfortable conversations?
Yes, I actually work with an organization called Partners in Health, which is out of the US, but they have a center here in Uganda. And they have a program called Connect Girl Child, which started even before COVID started. And I'm part of their technical working group. And what the program does is creating safety nets for these girls, reskilling girls that have dropped out of high school, who have no, additional opportunities to pursue mainstream education. But what also the program does is it works in collaboration with community circles. These are groups that savings groups at community level or community health insurance groups. So they work with those embedded community groups and women in the community, and they match the young lady to a senior other lady as a sort of a mentoring program. So if the young lady has a child and they are learning to be a mother, for example. They are paired with somebody who can support them, somebody who they can ask questions about, just how to raise a child. Imagine, having a child when you are 14 or 15. I think people just assume that, you just get into the role and suddenly, but, these are young women who need to lead at that level. They are making so many, many, many decisions, about their own agency, but also about now finally the child that they have. And quite often, the young man is not held responsible and is not even in the picture. So that's one program example that is really practical in terms of skilling, creating a safety net. But also it has a component of sensitizing men and young men to take responsibility within the community. So it's not a siloed all girl child program. It is cognizant of the fact that the men have to be part of that intervention.
So from your experience, what happens when women lead in global health?
I recently read Michelle Sidibe, the executive director of UNITES, and he wrote an article entitled When Women Lead, Change Happens and Results Follow.
Okay.
And I couldn't agree more. I think that's the simple response to that is, what happens when women lead in global health is that we do have results, undeniable results, and change happens. And I think we are living at a time when there are a lot of opportunities that are opening up for women. For many of us, whether you support the Republican or the Democrats, for example, to see a vice president who is a woman for the United States of America, that is powerful in so many ways. And I can't wait to see what change and results follow her leadership. We simply need, I think, to be savvy about capturing data related to women's performance and expanding and also expand the scope of the data dissemination and amplify the use of those data for decision making. I think that women are leading all the time. The gap exists, however, that actually demonstrate the results of their efforts. We may be seeing some of this data at the global level, but definitely not where I live. We don't have enough information to support women's promotions, to support women taking over executive roles, and so on, because men have a track record and they have data and they use those data to negotiate much, much better. So I think that we need to be a lot more savvy so that what happens when they lead, we do get incredible results. But we need more data to demonstrate that these results are happening, even in spaces where researchers haven't reached. So how do we harness those stories? The WHO says that health systems function better when women who manage them also have an equal say in the design and the delivery of the interventions. So we can see better results in global health if we are able to include the voices of women and women as a part, as co-constructors of those interventions when they have equal say in the design and the delivery of those. In the past 11 months, in collaboration with actually SEED Global Health in Uganda and in Ministry of Health and other leading institutions, a group of nurse leaders and midwives have started a program where we enhance the capacity of nurses and midwives to write their stories And we have also subsequently created a platform to disseminate those stories. We know that nurses and midwives, the majority of whom are women, mind you, have demonstrated impeccable leadership on the front line of COVID-19. They contribute significantly to the changes and the results that we are seeing in the COVID fight. And yet, their stories and often their contribution remains hidden and remains a by the way. So, yes, when they lead, change happens, but we need to capture those stories and we need to bring them into circles where decisions are being made about those very women.
Yeah, so we need to build platforms like what you just mentioned with Seed Global to get people to intentionally write these stories and put it down. But then in addition to that, data collectors need to be following the data. We can't sit and expect the data to be collected. We need to be intentional about collecting it. Yes.
Yes. And also, we need to rethink the way we invest, allow, enhance the capacity of the data collectors to go to the unreached places to get those stories and to hear about how women are impacting through their talent and gift and innovative practices, impacting communities and causing change within their own communities, and they are the champions of change. But we have to invest in that infrastructure, and for somebody to be able to go to, for example, here in far away places in Kaberamaido, the rural areas, where this kind of global health leadership that we are talking about is actually happening, but we simply don't know about it.
Okay. Nurses, a majority of whom are women, are often underrepresented at the decision-making and policy tables. So how can we grow their leadership capacity so that they can become agents of change within the health system?
This is one of my favorite questions.
Hey.
As I said, I'm a nurse by background, and I've received my education out of amazing universities. But I've also had incredible mentors in terms of leaders who I have followed for many years. I think my first response is where my passion currently lies is really we need to strengthen the nursing and midwifery education to match the pace of the change and challenge that is happening in the world around us. Most of the time, when you look at nursing and midwifery curricula in institutions in sub-Saharan Africa, you realize that the knowledge content and competency framework simply is not agile enough, to match the pace and the change that's happening. And these nurses and midwives are thrown into these chaotic healthcare systems where there's significant scarcity of resources and so on. And they are expected to be innovative in practice to impact patient outcomes. And you just think, well, the input has to equal the output. So we need to strengthen that. So that's one area that's my bread and butter. Very, very passionate about that. I usually have an illustration of, the current nurse, is split into so many roles. They are supposed to understand about strategic management and organizational culture. They are also supposed to understand about insurances. They are supposed to understand about the business of healthcare because of the emerging insurances and so on. But they are also supposed to understand about, the patient care processes and the illness process. And then they need to understand what's happening in the community. We are asking for so much without being willing to invest, so that we get them to a level where they can actually productively give us those kinds of outputs. The recent WHO World, the State of Nursing report, it really makes a point about investing specifically in leadership development of nurses and midwives. I've had a lot of talks in recent months, webinars about leadership. I have a series that I run every month called Inspire Leadership, again targeted towards nurses and midwives and other healthcare providers. And in one of my talks, a participant challenged me by noting that when nurses and midwives are included, when they are brought to the table, apparently they say nothing. And I wondered if nurses were given an opportunity to say something and they still didn't say something. But the question made me think about the issue I mentioned earlier, which is about enabling for leadership, enabling for solution making, and enabling for results. And I am a firm believer that a specific budget line needs to, be visible in every organization, in any ministry of health, any nursing department. There has to be a specific budget line for this level of investment. We can't simply talk about it and actually not put money towards that. If we want to see more enhanced outcomes globally, nurses account for nearly 80% of the workforce, of the healthcare workforce globally and almost in every country. So if we really want to see enhanced results, if we want to safeguard that workforce, we need to put our money where our mouth is, as they say. One of the other things that I usually talk about is, we needed to do succession training and mentoring, not planning. The previous language around this was always, people have to do succession planning and people have to do succession planning. The issue is that you can plan and plan and plan and still do nothing.
Yeah.
So, so this needs to be an action verb about this issue of succession in terms of actually training and mentoring. And each of us must ask, do I have someone I am training to take my job? And that should be something we celebrate. Do I have somebody as a female vice chancellor who is a nurse? Do I have somebody in the pipeline to actually take my job? And then finally, I really want to say that we need to, and this is really common, I believe, those structural, embedded structures and norms that we have maintained for so long. We need to shift from leadership by title to leadership by competency, so that the majority of leaders that we have in nursing and midwifery are not simply there because they have a title, but they are actually there because they have talent and we have invested in training them. Therefore, they have competency.
And you have centered your work on transformational leadership. Could you please explain to us what the elements of transformational leadership are?
Yes, thank you very much. So my doctoral work was influenced largely by two scholars, James Causes and Barry Posner, particularly their transformational leadership model. And this reflects 5 exemplary practices of leadership, known as modeling the way, where leaders are able to model the desired, leadership behaviors. So others are able to observe that. Inspiring a shared vision, being able to challenge the processes, enabling others to act, as we've just discussed, and also encouraging and celebrating greatness. So encouraging other people and cheering them on. So there are a lot of other dimensions to transformational leadership, but the majority of my work and training focuses largely on these domains.
And how can it be adopted in global health?
I think we can adopt by, for example, looking at the individual leader behaviors and asking what kind of a leader, for example, does the future global health require? These are really, so I'm the current leader for the global health movement now and the global health agenda. Now I would probably retire in 15 to 20 years. However, we are looking at increasing the scope and the number and the quantity and the quality of leaders for global health in the future. So I think I would like to be able to actually pose that question to the listeners. What kind of leader? And I think if we want to see a transformational leader, we also need to look at the organizational characteristics and processes. In this conversation, we've talked a lot about structural barriers and social norms that are toxic. So, we need to ask a question: what do we need to change? What needs to actually change for us to advance the global health agenda? And then, you have followers and groups. How are we inspiring? How are we recruiting talent? How are we enabling others in line with these domains from Barry and causes? And then, of course, the outcome. Are we documenting the impact and are we celebrating greatness? And we've already touched on these in our the previous questions you asked me. So how do we really adopt this in global health, specifically for women leaders in global health? What are the outcomes? We need to document this impact and we need to celebrate and recognize talent and greatness of global health leaders who are also women.
So finally, what are the immediate shifts that need to happen for us to decolonize global health and begin to create a more just and equitable future?
Before I get to that, finally, I just wanted to add one thing about the transformational leadership is that we need exemplary and effective leaders in global health. And we need leaders who can look beyond the current walls and who can reframe and broaden the vision of global health that advances global health equity. I think that's really important, So in terms of answering my own question, what kind of leader do we need for the future? We need leaders who are also courageous to identify context-specific prototypes and go on to champion change. So context-specific prototypes for interventions such as the Girl Connect one that I talked about, and also the leaders who can go on to champion additional change. So we have, an expanded snowball effect in terms of interventions that are impactful at the community level. But we also need equitable distribution of roles and resources. I don't want to cite all the statistics out there, that talks about how, only 3% of women are in leadership positions and so on. I think, we now know what the problem is. So let's get down to the business of, equitable distribution of those roles, of those promotions, and also of resources. Followership, which is a large component of what the transformational leadership is about, is really not about disempowering other people, but it is about empowerment of all individuals for a common good. And I think that is really a story worth telling. So now to your final question, it was about immediate shifts.
Yes, that needs to happen for us to decolonize global health and begin to create a more just and equitable future.
Well, I want to go back to my earlier mention of interlinked problems require interlinked solutions. So how our knowledge, our cultures, our language are all currently shaped routinely by the global north. Clearly, both positive and negative impacts of this. I'm actually not sure that we have readily available solutions for a rapid rollout. I think it's important for us to systematically address, for example, where we started, the historical, political, economic, the social, the global systems that adversely influence the global health agenda and constantly threaten global health equity. For example, an intervention we talk about but are reluctant to implement, and this happens all the time, the bidirectional or reciprocal knowledge sharing. So, decolonizing global health really comes down to not just this, but this is really important, a reciprocal knowledge sharing and creating a platform to be able to do that. Majority of the time, we still have that top-down approach. Decisions about global health, decisions about a woman who lives in the slum next door to where I live being made thousands and thousands of miles away from her. And the persons around her who live in community with her are not able to feed into that system of knowledge development so that we can co-create solutions that are contextually relevant to that woman. So a reciprocal knowledge sharing, I think, could go a long way. It's one way for us to start on that path of a just and equitable future in global health.
And that's a fantastic way to end. Wow. That was an illuminating and insightful conversation with Dr. Rose. The lesson I'm walking away with is that if we are going to start making changes to global health, ensure more equity, and create the space for nurses and midwives to thrive and lead, we need to start from the home. If you enjoyed this episode, I would encourage you to subscribe to the podcast and tell others about it.